Hello, friends, and welcome to the third episode of Literature in Review. I'm your host, Alicia Reve. This is a different format than I've had for the first two, and again, I'm just trying to figure out a way that will be reasonable for listeners. If you're watching the video, I've got slides up this time to help direct our conversation, and if you are simply listening to the podcast, hopefully just having the slides for me will keep me organized and taking up as little time for each topic as possible so that you can benefit as well. But if you do believe you would benefit from seeing the visuals, feel free to check them out on YouTube. And we'll go from there. Please give me your feedback and let me know if you prefer this format to what I've done in the past. So the topic for this conversation is a paper by Sakamoto et al. In 2016. And the paper is titled Determination of the Cutoff Score of an Endoscopic Scoring Method to Predict Whether Elderly Patients with Dysphagia Can Eat Pureed Diets. Also, please forgive me, I have pretty bad allergies right now, but I'm going to try to just kind of go through regardless. So just to start here, where it's published, this is published in the World Journal of Gastrointestinal Endoscopy. It's by the Baishi Deng Publishing Group, and the World Journal of Gastrointestinal Endoscopy is not listed in the SCIMAGO journal rank, which is the ranking that gives you an impact factor for the journal. But I did go ahead and link the page for this journal if you're curious about who's the editor and etc. So I don't have an impact factor for this journal, and I did look on PubMed Central, and as of January 19th, 2020, this paper had been cited 4 times according to PubMed Central. So who are the authors? The first author on this paper is Torio Sakamoto, and we've got 5 other authors here. I just cited where they work. Many of them are at Showa Inan General Hospital, including the first 5 authors. The final author is at the Department of Otolaryngology, Head and Neck Surgery at Kochi Medical School. So feel free to check that out on the PowerPoint if you're curious where these folks are working. And now we're going to dig right into the paper, starting with their introduction. So these are the rationale points that they've used to justify their study. So here's what they've got. They said that pneumonia ranks 4th in causes of death in elderly patients in Japan. And elderly, we mean 65 years or older. They stated also that most cases of hospital-acquired pneumonia are related to aspiration, and I'm going to talk about where that citation came from later. They said that if people can eat a pureed diet, they won't have to have a PEG tube, which would be a benefit to the patient. So that's why they're specifically targeting pureed diets in this study. And if people can eat a pureed diet, that would be better because we don't want to have patients getting PEG tubes if they don't need them. But unfortunately, we don't yet have a way to predict whether the patients will successfully be able to eat that pureed diet. So this study is meant to add a modification to a previous endoscopic swallow study, to a scoring method for that, to rate and see whether the subject hopefully will be able to eat a pureed diet if they have dysphagia, so we can avoid getting them a PEG tube. So in the previous scoring method, it was attributed to the last author, Masamitsu Hyodo, and in that setup, they used a blue liquid. In this one, the protocol includes a test jelly, and there are specific properties of that jelly that are reported in the paper. And that is meant to help us predict, in the case of this study, whether the subject's going to be able to eat a pureed diet. So previously with the blue liquid, we had the Hyodo scoring scale for the endoscopic swallow study, and now it's the Hyodo Komagane scale using the test jelly. Moving on to the study design details, they ended up with a total of 178 patients with dysphagia who were 65 or older included in the study. They were patients at Showa Inan Hospital in Japan between January 2012 and November of 2014. And all of the subjects provided consent, and they all did the endoscopic swallow eval. For brevity in the rest of this commentary, I'm going to refer to that as FEES, which is fiber optic endoscopic evaluation of swallowing. They did not call it FEES in their study, but for me, that's the best shorthand that I know to refer to an endoscopic swallow study would be FEES. As I mentioned, the subjects were over 65 years old and no acute infections. And after they did the endoscopic swallow evaluation, their diet intake, so what they actually ate, was monitored for at least 5 days, and those are the subjects who were included. Overall, we had 113 males, 65 females. The average age of these subjects was 83 years old. The youngest was 66. The oldest was 98. So I guess that clarifies we're not including 65-year-olds. It's 66 and up. And they did provide a table telling us about some of the comorbidities of these patients. So 38% of the subjects had cerebrovascular disease. Oh my gosh, I wrote cerebrovascular. I'm sure that's cardiovascular disease. Please pardon that. 32% had aspiration pneumonia. 20% of the subject participants had neuromuscular diseases, and there were 10% of subjects who had other comorbidities that they didn't break down further. So what did they do in this study? The subjects swallowed test jelly under video endoscopy under FEES, and then they used a scoring scale called the Hyodo Komagane scale to rate the FEES. And I'm going to explain fully what the Hyodo Komagane scale is on the next couple slides. So based on the results of that swallow study and the rating that the subject got on the Hyodo Komagane scale, they were either recommended a diet or they were not. Over at least 5 days after they took the FEES, the subject was monitored to see whether they were consuming enough of their prescribed diet, whatever that was, to meet their nutritional needs. And they continued monitoring the subjects regardless of whether they ate enough or didn't eat enough. And then the researchers ran an analysis pretty much to see whether there was a specific score that subjects had gotten on the Hyodo Komagane scale to see who was quote-unquote successful and who wasn't with their prescribed diet. So as I mentioned, I'm going to explain what the Hyodo Komagane score, what those scores mean. And what's really nice is this study does provide a complete picture of the scale. Just like if you go online, you can easily Google the penetration aspiration scale scores. In their paper, they have the full outcome of what all of the topic areas are and what all of the point systems are. So I'm going to walk you fully through the first one, and then I'm going to tell you the remaining 3 categories. So overall, you can have a maximum point score of 12 on this scale. You have 4 different items. Oh, is that correct? Yes, and yeah, it is. Okay, so there's a total of 4 different items that you rate and 4 different rankings under each one. The maximum score is 12, but there are a maximum of 16 different scores that people could get, but the lowest score on each item is a 0, so that wouldn't contribute to your point scale. So rather than having it be 1 to 16, it's 0 to 12. If you have a score of 0, that would mean that everything was normal on your test, and if you had a score of 12, that would mean you got the worst score in each of the 4 components that you possibly could, worth 3 points each. So the first one here is salivary pooling in the vallecula and piriform sinuses. So a score of 0 would mean there's no pooling in either the valleculae or the piriform sinuses. A score of 1 would be that there's some pooling of your saliva, only in the valleculae. A score of 2 would mean that you have a pooling of your secretions in both the valleculae and the piriform sinuses, but there's no penetration into the larynx of those secretions. And then the last component, which would be the max score of 3, higher points is worse. This is like golf. A score of 3 here would be you have salivary pooling in the valleculae and the piriform sinuses, and there is penetration into the larynx. Now, if you're curious as to what they mean here with penetration, I defined it for you as they did in their study. It's defined as, quote, when saliva or the test jelly enters the glottis, which is the opening to the trachea, and moves as far as the vestibule above the true vocal folds. Now, this is possibly a language barrier issue because we know that if the material enters the glottis, it's already at the level of the true vocal folds. So aspiration is actually when material would go below the true vocal folds, and penetration would be the materials anywhere from, anywhere inside the laryngeal vestibule up to the true vocal folds. So it might just be an ordering issue here, and there's not necessarily there's not a worse score for aspiration than there is for penetration. But if you had saliva or test jelly going into the glottis, then that would be aspiration. So this is just a point of a little bit of confusion on this scoring metric, but you can assume that if the person had a score of 3, it could be penetration or aspiration. We're not sure, and this scale does not really differentiate the two. So the remaining items in broad categories are the B is the response of glottal closure reflex induced by touching the epiglottis with the endoscope. And they did make it clear that they would tap the endoscope to the epiglottis about at least 3 times. So they would tap 3 times. If you didn't have a reflex closure the first time, they tried a couple more times. And they mentioned that they wanted to do this because they didn't think just trying once would really ensure that you actually touch the endoscope to the epiglottis. And same thing, you've got a 0 to 3 scale here, so my assumption, I didn't put it all down. I can actually look. I didn't want to put the entire thing in my slides because I do want to direct people toward the actual manuscript. But in B, for the response for glottal closure reflex, you have a 0 is a marked reflex by 1 touching. A 1 is a slow and or weak reflex by touching. 2, a score of 2 is a reflex with 2 or 3 touchings, and 3 would be no reflex despite 3 touchings. We can talk a little bit more about this item. This is one of the questions that I had. I actually reached out to Vince Clark about this because I wasn't sure what this glottal closure reflex is, and there was a paper that he referred me to that said that there are a number of different closure reflexes, none of which did I see are induced by touching the epiglottis with the endoscope. I'm familiar with, in older FEES testing, FEES with sensory testing, you would do a puff of air onto the arytenoids and look for a closure reflex there. So for this particular item, I'm not really understanding very much what this reflex means or whether they were inducing the correct reflex with the correct touching pattern. So I guess we'll table that. If you have more questions about it, let me know, and I can forward you the papers that Vince suggested to me to read on this topic. And thank you to Vince for talking to me about that a little bit because I was pretty confused, and I know him from working for a FEES company in the past, which is why I reached out to him with my questions. Item C is the location of the bolus at the time of swallow onset assessed by the whiteout following swallowing of the test jelly. So basically they were looking to see, whiteout again is where you have a squeeze or closure of the structures in the pharynx where the tip of the endoscope is sitting with the camera. And whiteout is just a flashback of the picture of the light from the camera. So you can't see it because basically the structures have closed off. And they're saying, where was the bolus when there was maximum constriction that caused a whiteout effect when swallowing the test jelly? And again, on this one, I'm not aware of any standards for where the head of the bolus should be at the time of swallow onset. But I do know that judging swallow onset on video fluoroscopy is very different from assessing swallow onset on FEES because a lot of times we consider swallow onset in video fluoroscopy to be the start of hyoid burst, which if you've watched a bunch of video fluoroscopy, and please let me know in the comments if you disagree, but the hyoid burst happens, excuse me, quite a bit sooner than pharyngeal squeeze does. Please excuse me. Again, my allergies are really problematic right now. So on this item for the location of bolus at time of swallow onset assessed by whiteout, so a 0 score would be if it's in the pharynx, a 1 score would be if it's already in the valleculae, 2 would be if the bolus is in the piriform sinuses, and 3 would be that there's no swallow. So presumably no whiteout. Although I think it's a little bit interesting that a person could swallow without there being whiteout. We've seen that with reduced range of motion of the pharyngeal constrictors or base of tongue. So again, that's not something that they addressed later in the study, but something that you might want to think about if you're considering adopting this scale or something like it. And then letter D is the extent of pharyngeal clearance after the swallowing of the test jelly. 0 would be no residue. 1 would be there's residue, but they were able to clear it after after 2 or 3 swallows. 2 would be there's residue that remains, but it does not penetrate into the larynx. And a score of 3 would be that residue remains and it penetrates into the larynx. So I'm not sure that this scale is completely comprehensive because, again, if you don't have a swallow, I guess you could have like a 2 or a 3 as your score on this one. So if in letter C you don't have a swallow, you would get a score of 3. And then in D, presumably you would have either there's residue and it doesn't penetrate, or a 3, there's residue and it does penetrate. So they didn't really address this, but something for you to maybe keep in mind. So here were their results. 126 of the 178 patients were prescribed a diet to eat, either puree or something less restrictive. The remaining 43 patients were basically seen to fail the swallow screen, the instrumental swallow study, because they had penetration. Wait. Excuse me. So for the results, we have 126 of the 178 patients who were given pureed diets or less restricted, meaning let's say it was like a regular diet or maybe what we would say here like a mechanical soft or minced or soft solid diet, and they were successful. So again, successful was determined by eating enough to maintain your nutritional needs. The remaining 43 patients were judged to fail because when they were eating the pureed diets, they did not eat enough to meet their daily nutritional needs. Now again, realize that this is sort of like a functional outcome and doesn't mean that they weren't safe with their pureed foods, but that they didn't eat enough of it. And we're going to dig into that a little bit more. So taking these 126 successful, 43 unsuccessful, which now I'm looking at this and the math doesn't quite seem right. It would be like 42 patients, right? Or 52 patients. Interesting. So I'm not sure why the math here doesn't match up. I'm confused. Okay. 126 were able to eat pureed or higher or less restricted diets that fulfilled their daily nutritional needs. It says the remaining 43 patients were judged to fail. But again, the math doesn't add up because 126 plus 43 is 169, but we had a total of 178 patients. So I'm curious where the other ones are, but this is not a mistake that I made in reading it. It may be a typo in their work here explaining the remaining subjects. Regardless, if you apply a cut score of 7 on the Hyodo Komagane scale, 100% of subjects who got a 7, 6, 5, 4, 3, 2, 1, or 0, all of those were eating their prescribed diet and meeting their nutritional needs. How that was defined, again, I'm not sure. We'll talk about that a little bit later. If the subject got a score of 8, some of those ate their diet to meet nutritional needs and some did not. Now, if you had a score of 9, 10, 11, or 12, that included all the patients who were deemed unsuccessful with their prescribed diet. So per the authors, they had some limitations to their study. One was that the subjects were older. 2 was that their design was retrospective. And 3, they said there were no comparative data using established competitive techniques. I think that means they didn't compare their scale to another established scale. So, for example, like let's say it was a scale of penetration or aspiration, and they compared it to the Rosenbach penetration aspiration scale score. They didn't have another scale to compare this to. I don't know if that means that they don't have other techniques of scoring this, or maybe that there just aren't other techniques for the use of a test jelly. But regardless, that's what they said their limitations were. Now, I have my own commentary on this, and here's a lovely picture of me covered in glitter. And full disclosure, today is actually the 22nd. It's a few days after I initially made this PowerPoint, and I probably should have recorded it several days ago because my allergies weren't so bad. So starting off, the first main problem I had that I wanted to address was in their introduction, where they said that most pneumonia is related to aspiration. So I found that study. It's Sakamoto 2009. And in their study, the title of the paper was High Incidence of Aspiration Pneumonia in Hospitalized Patients, a multi-center prospective study in Japan. This was published as a letter to the editor. And again, I'm not sure whether letters to the editor have to pass a peer review process or not, but just note that. And in their paper, they used the definition, of aspiration pneumonia per the Japanese study group on aspiration pulmonary disease. It states, quote, pneumonia in a patient with a predisposition to aspiration because of dysphagia or swallowing disorders. So for everyone thinking that aspiration pneumonia is a differential diagnosis that you would get from doing, for example, a biopsy of the infected material from the lungs, or you would do specific imaging to see where the location of the infection is, something like that, that is not accurate. The definition of aspiration pneumonia per this study group is that it's any pneumonia in a patient who has a predisposition to aspiration because of dysphagia or a swallowing disorder. Okay? That's not necessarily including patients with reflux, and this is certainly not something that required testing to confirm the presence of aspiration pneumonia. It was just, does the person have pneumonia, and are they predisposed to aspirate because of a swallowing disorder? Boom, aspiration pneumonia. Again, I would be happy to dig into this further. For this study, again, this was the foundation, one of the foundational pieces used to justify this study. And in this Sakamoto 2009 study, patient swallowing function was assessed with, I think, like 6 different ways. It could either have been a water swallowing test, the repetitive saliva swallowing test, the simple swallowing provocation test, video fluoroscopy, or the presence of overt symptoms of dysphagia, or a medical history of aspiration. So I don't know if you guys can hear, there's a sweet puppy sleeping next to me and her breathing is very loud. But if you were looking at saying, okay, well, we can be pretty confident that aspiration is the cause of pneumonia because of imaging, the CT scan shows us where the pneumonia is, and we can infer that this was caused by aspiration. Those are not the parameters used in this Sakamoto 2009 study. So for me, I don't love that at all. But if you'd like to hear more on this topic, please just let me know. I also had an issue with the way that they determined whether a Puree diet intake was successful or not. Again, it was determined by whether you met your nutritional needs, but there's no mention of how that was determined. For example, was this avoidance of weight loss over 5 days? Was this determined by consulting with the nutritionist? So we're not sure, especially for patients who, I don't know if this is as big of a problem in Japan as it is in the United States, but nutritional intake may depend on the body mass index or weight of the patient at intake. So some patients, if they're malnourished when they're admitted, they might need more caloric intake than a patient who is overweight, but a patient who's overweight and also dealing with wound healing may need a higher caloric intake. And in this particular population, we don't have any commentary on those different variables. So when they say, okay, this patient ate enough to meet their nutritional needs, I would like to know how that was determined. I would also like to know, whether there are additional factors like, did the patient have a family member bring them food and they ate the food brought by a family? And again, I don't know whether this happens in Japan, but in the United States, it could be the case that your relative brought you Kentucky Fried Chicken and you ate all of that so that when you got your pureed meal from the hospital and you didn't eat that meal, it might be because you already ate a meal brought in by a family member. I don't know whether that's the case in Japan, but I am curious about that. I also noticed there was no mention of the consistency of liquids. So you could either assume that the person is having a full pureed diet, so their liquids and foods are having the same pureed consistency, or you could say, okay, well, we're not actually sure what the liquids consistencies are. And again, presumably because patients could have had multiple diets, it was either pureed diets or better. We're not really sure how many of the patients had an unrestricted diet, how many had mechanical soft. Were all of the liquids thickened? Did they depend as well with the consistency of the foods? And I'm not sure on that. And then I also think there are some potential confounders, as I mentioned with, if your family brought you in food so you didn't eat the food on your meal tray from the hospital, that's not clear. And it's also unclear whether they checked for additional factors that would influence whether the person ate their full meals, including whether they had appetite problems or whether they just didn't like the hospital food, or if there are other cultural factors. I'm really not sure what is standard in hospitals in Japan. I don't know what people generally feel about thickened liquids or pureed diets. I do know that can vary culturally and personally. So that would be something to sort of, if I had been on the study team, I would have liked to include these different parameters. I think that would have made the study stronger. Finally, I wanted to sort of talk about dysphagia and what you can assess with an endoscopic swallowing study. Obviously, we know that if people specifically had problems in the oral phase, FEES is not capturing that. Might not be as important given that in this case they were specifically looking at a test jelly. I just don't know whether they also looked at other consistencies in addition to the test jelly. So for example, if the person is a gold star swallower with pureed consistencies, did they test less restrictive consistencies that maybe they didn't rate with the Hyodo Komagane scale, but that helped the SLP determine what kind of diet they would recommend? I'm not sure. We also don't really get any of the behavior from the pharyngoesophageal segment and below in the upper esophagus, which you could potentially be getting with a video fluoroscopy. And we didn't actually get any conversation in this paper about the underlying pathophysiology for the dysphagia in these patients. Again, they did talk to us about some of those comorbidities, but they didn't explain why the subjects had dysphagia and what kind of dysphagia it was. As I mentioned earlier, I was concerned with this testing of the glottal closure reflex. When I was talking to Vince Clark, he was telling me that testing the laryngeal adductor reflex, glottal closure reflex, other pharyngeal laryngeal reflexes that are meant to aid in lower airway protection, he was saying that those aren't really standardized as part of the FEES testing that we do here in the United States, And he was saying if you don't get a glottal closure reflex, we're not really sure how much it means. Similar to when you do cranial nerve assessing in your oral MAC exam and you don't get a gag reflex, we don't know how important that actually is to swallowing. So it's kind of a thing that you can test, but maybe it doesn't deserve equal weighting as another item on this assessment that could be very clinically meaningful, like salivary management and the management of pharyngeal residue, for example. Those two seem like pretty important clinical measures, but I'm not sure about the glottal closure reflex. And further, I'm really not sure about tapping the epiglottis to elicit that reflex and whether that's standard or if there might be a better reflex to look at. For example, it would have been interesting for them to add a component that talked about the subject's response to penetration, whether they had an ejection response, either being a swallow elicited or closure or partial closure of the glottis when the material starts to penetrate into the laryngeal vestibule. Those kind of might have been a little bit more clinically meaningful in my opinion. And then, as I mentioned earlier as well, when I was talking about the Hyodo Komagane scale, they didn't really have a clear definition to differentiate penetration from aspiration. And I don't know whether doing that would be more diagnostic. It would be interesting to see. But to the best of my knowledge at this point, I don't know if, and maybe it doesn't make a difference, but regardless, they did not distinguish between the two. And for those of us used to the penetration aspiration scale score, we are used to differentiating between penetration and aspiration. So it was just something that I noticed. So overall, my favorite parts of this study and this publication, I really liked how they showed me the data. They showed me the distribution table for the Hyodo Komagane scores. So they showed me exactly how many subjects got a score of 0, how many got a 1, 2, 3, 4, 5, 6, and 7. And then they showed me the relatively fewer number who got an 8, 9, 10, 11, or 12. They also had a nice inclusion of images from fees to help the reader understand the scoring on individual items. And I love that they included the entire scoring table for the Hyodo Komagane scale, which I think is great for anyone who wants to actually understand what the scores mean. I can't stand it when studies say we used XYZ scale and it's published somewhere else, and you're left thinking, okay, so do I need to pay for 4 more articles to figure out what this scale is, whether it's reliable, valid, and so on. So I appreciated that they actually had the full scoring table. So if you did want to use this, you could, and you could reference this publication, especially if you had the test jelly. Now, in terms of the test jelly, they pictured what it was and they talked about their rheological properties, so I thought that was really good. There was a clear rationale for why this study would be important. Again, I don't necessarily agree with all of the papers that they cited, but it did make sense to me why they were doing the study, what they hoped to achieve, and I don't think that they necessarily overstated the benefits of what they found. So I appreciated that. And then one last thing that I don't think is necessarily as hyped as it should be, but this study is published in English, and I would say generally the English in this study is pretty clear. And the reason that I want to just point this out as a benefit, I'm not going to, overstate and say that these folks who wrote this paper are my colleagues, but as I'm getting a research degree, I do appreciate it, and I appreciate that they've gone to that extra effort to make it something that I can read here in Florida when they're over in Japan, and I'm not going to do the same favor for these folks, which is sad. I'm not going to be able to translate my papers into Japanese, and I don't know that it would be expected of me to do that, but I do appreciate that they went through the effort to get this written in English, and they did have a medical doctor help them with the English of their paper. They said thank you to David Y. Graham, MD, for helping with the preparation of the English manuscript. So thank you from me to you as well, Dr. Graham, because I also appreciate that I got to read this paper. Okay, and then my unfavorite parts, as I mentioned, I don't like how they did not fully describe what successful oral intake meant, how they determined what the goals were for these people, and how they didn't control for compounding factors. It's unclear to me whether the liquid consistencies were modified and to what degree. And I would have really liked to see a distribution of the diet types. So of the 178 patients, what were all of the diets that were described? Put it in a histogram. 42 had regular with thin liquids. 68, this is, for example, these are not real data. 68 ate pureed diets with thick liquids as well. So I would have liked to see that distribution breakdown, and it would have been very nice statistically to see what the success rates were per recommended diet. And I would have also liked to see what kind of dysphagia there was. I would have liked to see, that component to differentiate different types of dysphagia. And I certainly would have liked to see a descriptive or qualitative component to this study addressing the oral intake by patients. How do they feel about pureed diets? How do they feel about the diet that they were recommended? If they were not successful, maybe you don't even have to ask the people who were successful, but for those who did not, quote unquote, successfully eat their given diet, why not? Was it an issue of, did they have weight loss? Did they not like the food? Did they have a loss of appetite? Were they taking an additional medication that made them very queasy? So I really would have liked to know those things, and I think it would have strengthened this study, in my opinion. So what I would take away from this, if I'm a clinician out in the world, if I were a clinician, I might play around with this Hyodo Komagane scale, and I might play with it to see whether it's a nice way to maybe predict diet success in my patients, but more specifically, it might be nice to track change over time if I'm allowed to repeat these on my subjects. I think this scale would be even more useful clinically if paired with some of those descriptive components. So if I did want to use this clinically, I would add those descriptive components. How do people feel about it? In the case of adherence, they didn't mention this at all in the Japanese study, but if I recommend pureed intake to my patients and they're not going to eat puree, I would like to also comment on that. I would point out just, we're not really talking about oral or esophageal issues here at all, but if you did have someone specifically where you were concerned with residue or secretion management, I don't know if this scale would be sensitive enough to track change in that, but maybe it could be useful. If you were able to get your hands on the test jelly, that would be nice because standardizing that makes the study repeatable and reliable. I don't actually, now that I'm saying that, I don't actually recall how much they had the subject swallow. I feel like it was maybe 3 milliliters. Let me just double check that real quick if I can. When the test jelly was absent from the pharyngeal cavity, it was deemed a successful swallow. Let's see. Test jelly. How much did they swallow? Yeah, having a specific volume. Yeah, it's 3 milliliters. So also just bear that in mind that it's different from a lot of protocols here where we would do like 5 milliliters on a spoon of like a pudding thick material. Again, bear that in mind. And then pharyngeal sensory testing of any kind should be paired with a descriptive aspect by talking to the patient. So if you are tapping around the epiglottis, arytenoids, pharyngeal wall, or so on, I would ask the patients whether they can feel it. And again, whenever we do that, the same way you do your oral mechanism exam and you're stroking cheeks, you're going to ask them if they feel it even when you don't touch to take away the report of false positives. And then I think the idea of collaboration is also a good point here. So this is in the World Journal of Gastrointestinal Endoscopy. And, they did include a speech therapist in their protocol. And I think it would be great to continue to work with other people who have a different perspective. that wraps this up. Again, my name is Alicia Reve. I'm a doctoral student at the University of Florida. You can email me at my UF email, which will go to public record. If you have something more sensitive you'd like to ask about, please feel free to use my personal inbox. I'm going to continue to provide that until I'm told not to. And please give me feedback on whether you prefer this format, and let me know if you have other papers or topics you'd like to hear about, or if there are preferences in the way that I present the material that you would like me to know about, so I can potentially adjust my style to make this more useful for you. Thanks very much for your time, and hopefully I will speak to you again soon. Bye.